Thanks very much, everyone. It's my pleasure to talk about a topic near and dear to my heart, which is HPV and cervical cancer in women. And I'm also going to do my best to talk about anal cancer, but I do not pretend to be an expert in this space. As is more customary in Canada, I want to recognize I'm presenting on the lands, and I'm not going to probably pronounce this right, of the Coochtank and Piscataway people, who are first residents of the land that would become District of Columbia, and I live, work, and play on the unceded ancestral territories of the Coast Salish peoples. I do have to disclose that much of the work we've done in cervical cancer and HPV has been supported in kind by Merck with a generous supply of vaccines and assays, which have been very helpful in moving this work forward over actually a couple of decades. And we've also been supported by our CIHR and Public Health Agency. So I'm going to just sort of start by talking about cervical cancer and doing a little bit of sort of, kind of the pathology of it, presuming that not everybody in the audience works in this space and is more sort of centrally in HIV. So cervical cancer, as I'm sure you know, is one of the most common and deadliest cancers in women worldwide, with over 300,000 deaths per year. And what is almost unique about this particular cancer is we know that it's almost always caused by a virus. And so this is unusual in the cancer world, but also a great thing to capitalize on. And there really has been a call from the WHO for elimination of cervical cancer, which feels within our grasp, but we're certainly not there yet. So as I said, HPV does cause cervical cancer, but non-oncogenic strains of HPV are also responsible for significant burden of sexually transmitted diseases and is the most common sexually transmitted infection. And so we do divide the many subtypes of HPV into the low-risk, non-oncogenic, and high-risk oncogenic. And 16 and 18 in the general population, and not so much with those living with HIV, are the primary etiologic agents for cervical cancer. And so a lot of the screening assays are focused on 16 and 18. So just as a refresher for those that don't live in the gynecologic world, what we're talking about is actually the squamocolumnar junction, where the differentiation of squamous epithelial cells occurs. And what HPV does is it infects these cells and actually ultimately can sit in those cells as in episomal form, be cleared, or can integrate and actually cause abnormal cell growth. And so really this is what we see, a nice, normal, healthy cervix there looking good. And then as we progress through different stages of dysplasia through to invasive cancer, you can actually visually see these changes when you look under a high magnification colposcopy. Now, the progression of this, however, does happen over usually about a 20-year time period, but HIV actually accelerates this and shortens this time period to CIN3 or cervical cancer. And our goal is always to detect and pick up this disease in its pre-invasive form, where actually ablative therapies are highly curative. And so we really have an opportunity with this cancer being essentially sort of semi-exterior with the opportunity of treatment and elimination. So what is the impact, the interface between HIV and HPV and cervical cancer? Well, it turns out that actually HIV facilitates the behavior of HPV, and it increases the expression of certain genes, which actually increases the risk of the development of the oncogenic invasiveness of this. And there are HIV TAT proteins that actually affect that, and the genes increase the likelihood of the oncogenic transformation. So it's not just sort of the epidemiologic associations between HIV and HPV, but there is actually a biologic interface and a helpfulness of these two viruses with each other. So women living with HIV have approximately 6 times more likelihood to develop cervical cancer. And it's really related to the fact that they have a higher rate of persistence of the virus, lack of clearance, and then the ability to progress. Now, just to talk about sort of the global picture, we have, as usual, and it's been talked about already this morning and will be again, is that we have a imbalance in prevalence of both cervical cancer, HIV, and HPV vaccine programs. So we have preponderance of cervical cancer in sub-Saharan Africa and low and middle income countries, and cervical cancer mortality is the highest in sub-Saharan Africa. And then we have HPV vaccine programs. I'll talk about HPV in a minute, where the higher income countries have been able to deploy these, and low and middle income countries have had more challenge in deploying vaccines at a population level. And then we've got HIV, sorry, I keep touching this, HIV overlapping in a very similar way, as you know. So it's really a double problem. So as I mentioned earlier, WHO has called for cervical cancer elimination. They have a 2030 target, and they have a real vision of a world without cervical cancer. And it feels like it's within our grasp, but we're certainly not there yet. And what that actual technical term of elimination is from WHO is below 4 cases per 100,000 women years. So the goal is to have 90% of girls. So the idea with vaccine is to, in a perfect world, prior to sexual debut, girls are vaccinated because this is a preventative vaccine. And then we have more than about 3/4 of individuals screened, and then 90% receiving treatment. And so this is a goal that we have yet to achieve, but it's many decades out. So let's just talk about HPV vaccines for a minute. So initially there was a bivalent and quadrivalent option available, and the only real distinction was that the quadrivalent option had activity against the non-oncogenic sexually transmitted 6 and 11, but both of those had 16 and 18. And then the quadrivalent was then moved into a nonavalent product, which has more of the oncogenic types in it to try and cover a greater proportion of cervical cancer. So this was an advantage. So what has been extraordinary with these vaccines is they have great safety profiles. Surprisingly, they're highly immunogenic. When you kind of think about the way this vaccine is made and the way cervical cancer develops, it was a wee bit surprising they were as good as they were. High retention of antibody levels, and very efficacious, about 90% in the general population in the per protocol arms. And then we've got ecologic data in countries who have had high deployment of HPV vaccine, where we've had high effectiveness against cervical intraepithelial neoplasia. What was very pleasing to see, however, is that generally speaking, persons living with HIV did have a seroconversion, but there was generally a reduced response. So in order to get to this elimination target, one would think, well, just deploy the vaccine and we're good to go. But the problem with that is the vaccine timeline to actually show benefit is many, many, many decades. So the other piece that needs to be considered in parallel and continued is intensive screening as well as vaccination. So that's how we can possibly get to this elimination goal. So we have to have the sort of two-pronged strategy. And that's just articulating this again. So scaling up of screening and treatment to all parts of the world and all women who and persons who have cervices, expanding the vaccination programs, maybe not just to school-based, but also other age groups who've perhaps missed vaccine, all persons living with HIV, and then really trying to target at-risk populations. Oops, I didn't mean to do that, sorry. And primary prevention with HPV vaccine is critical, but we definitely don't have total uptake, so we really need to continue with screening. And even with a vaccine, we won't probably ever be able to eliminate the need for a screening and treatment program. So cervical cancer screening historically has always been cytology-based in most parts of the world with the classic Pap smear. So that's essentially been a scraping of cells from the cervix and then looking at those, at least initially under manual microscopy, to see the actual change in the characteristics of the cells. And that actually was really a transformational intervention that started about in the 1950s, and in fact British Columbia was very instrumental in starting a population level screening program and has really been very good. However, the problem with that is it's a pelvic examination. It requires the cytotechnology to be able to do it well, and so the rollout across the world has been variable. However, now that we know that HPV is the primary cause of cervical cancer, HPV testing as a primary cancer screen has been coming in. And the beauty of that is, in fact, women can self-swab. So it doesn't require a speculum examination and a care provider with that sort of training. And in fact, it's been shown to be more highly sensitive and better reassurance with a negative test and the self-swabbing, as I mentioned. With individuals living with HIV, essentially the algorithm is HPV positive with oncogenic type and colposcopy. So there is the need for that assessment and treatment capability, and that again needs to be scaled up across the world. So I just want to share a little bit of the data from our Canadian HPV vaccine study, just to show one slide on some of our HPV types. And Kate Hankins, I don't know if Kate's still here, but she was involved in looking at HPV in cervical cancer for nearly a decade, and then we moved into looking at HPV vaccine. Many individuals in this room have been helpful in that regard, Sharon as well. And then we were able to show that there were high rates of seroconversion, but there was a better antibody response when women were already on antiretrovirals and virologically suppressed. So timing of vaccine can be optimized there. But one of the things in one of our analyses that I wanted to highlight today was that we were able to look at the original prevalence of HPV types in individuals living with HIV, and we actually had 45% of our participants with at least one oncogenic type, and the balance of 16-18 versus others was different. So 16-18 does not seem to be as dominant in persons living with HIV, so that affects some of the kits that are used for screening, and affects the kind of vaccines that we want to be supporting for women living with HIV. And then what we see here is rates of persistent HPV, genital warts, and CIN2 in historic unvaccinated group versus vaccinated, and we're seeing what we hope to see, which is significant reductions in persistent HPV, genital warts, and CIN2. And we're now looking at the 9-valent vaccine to see, so the other thing that's happening globally is we're doing dose reducing to 2 or 1 doses, which is less costly and easier to implement. And the question is, can we do that in persons living with HIV? And we're looking at whether that 9-valent vaccine can be used in a 2-dose or maybe even in a 1-dose regimen, which really would be so much more feasible around the world. So moving to other HPV-associated cancers, so cervical cancer is not the only disease that HPV is associated with, and anal cancer is another major one, but also important to note that some of the vulvar and vaginal cancers are associated with HPV, oropharyngeal cancers, and so there is more to the HPV story than just cervical cancer. And this is some data from U.S. tissue banks where you see proportion of HPV positivity in these different cancer types. And we see that, in fact, anal cancer has a high proportion of HPV, but also in particularly younger women with vulvar and vaginal cancer, HPV is also a player in this. And although the data is not great, we're very hopeful that the oropharyngeal cancers and other cancers will also, there'll be side benefit from rollout of HPV vaccine. So anal cancer is, fortunately, a relatively uncommon cancer in the general population, but it has been increasing, and certainly in men who have sex with men, this has been considered a real concern, exacerbated if there is co-infection with HIV. It's always been a less common disease in women, but not an unheard of disease in women, and I think it's been a kind of the forgotten cancer for women. And so we're still seeing, although men with HIV, the majority of men, or a quarter of men with anal cancer are HIV infected, a very small proportion of women are HIV infected, but part of it is we're not really studying this disease to the same degree. And it is sort of advantageous in a way that we show that 88% are associated with HPV, so leaves some opportunities for prevention with both vaccine and with potentially screening. So we need to consider women in our considerations of anal cancer prevention. The problem that has plagued us a little bit is it doesn't have quite the same relationship to cervix, where there's sort of a very linear progression from low grade to high grade to cancer. Anal cancer doesn't behave in quite as neat and tidy a linear fashion. Treatment has been very uncertain as to whether it actually prevents cancer because it's such a field effect and it's a much larger surface area. And so we've had some challenges in that regard. But of note, HIV-infected women are more likely to have the same HPV genotype in anus and cervix than uninfected. So when we see it in the cervix, it does make us concerned about anal infection. So until recently, there wasn't a lot of solid data, as I said, around treatment. More recently, Joel Palevsky has been working for many years in this space. He published a trial, an anchor trial, where he looked at treatment versus non-treatment. So he actually was ethically able to randomize to electrocautery ablation versus observation, and showed that in fact cancer progression was reduced in those who were in the active treatment arm. So this really has sort of, I think, finally said, yes, if you detect it, you should treat it, because there's been some argument about the morbidity of treatment and whether it was really doing what we wanted it to do. So despite this, I think there is a bit of uncertainty globally around how we should be screening, particularly in women, and how we should be treating. And the big problem, at least locally and I think globally, is that we don't have enough providers with the expertise and anal anoscopy and treatment to actually implement this at a large scale. So this is the International Anal Cytology Consortium that put out this proposed screening algorithm quite recently, and I'm not sure how well you can read it, but they're saying people who have a cancer incidence of greater than 17 per 100,000 should go into the screening algorithm. And if you can see, persons with HIV who are women over 45 and or have vulvar dysplasia or vulvar cancer, and or solid organ transplants should be put into an anal screening program. And that's where they're saying an exam plus either cytology or anal HPV. Anal cytology is harder to come by in most places, and the expertise around it is limited, and HPV testing is much simpler. But that's where the recommendation is at. And then for those without HIV, then there's some debate and shared decision-making. The correlation between cervical dysplasia and cancer and anal is not perfect. One is concerned if it's there, but it doesn't necessarily predict anal cancer. And then, as I said, you've got to have high-resolution anoscopy. You have to have access to that, and then you have access to treatment to make this whole screening algorithm work. So it's a work in progress for us, but I just put that out for thought. So role of HPV vaccine, we've really got to have it available, and then I'm just going to move to this last slide. So really, just to summarize, cervical and anal cancers are more common in women living with HIV than without HIV, that there are more oncogenic types, and there's more persistence in this population. The vaccine is a key preventative tool, and we need to roll it out very effectively in the right dosing regimen for this particular population, and ideally we can prove that 2 or 1 dose is non-inferior. Optimal screening for primary HPV for women living with HIV is not entirely clear, but it really looks like if you're able to get primary screening and self-screening, that's excellent. And then we're recommending 3 years if HPV negative. And then the anal screening looks like over 45 plus HIV would be an indication. And what we don't quite know yet is whether the HPV vaccine, although we suspect it will prevent anal cancer, it hasn't been fully proven. So I think I will stop there and thank the participants in all our studies, our team, and our supporters. And I just wanted to show how many sites across the country participated in some of our HPV vaccine trials, which has really been outstanding over a couple of decades. So thank you.